Well, thank you, Luis, for your invitation. Well, I think in this workshop we'll talk a lot about math and about physics. So it's the only presentation about clinics. As Luis previously said, the definition of voiding dysfunction, the ICS definition is abnormally slow and incomplete micturition based on symptoms and aerodynamic investigation. So it's a very wide definition. Of course, the causes have already been described: the Truser underactivity or acontractility and bladder outlet obstruction. Well, this is what we call an urologic iceberg. This had been previously described for a lot of urologic pathologies. What it means is that the actually number of patients that we see are very few compared to what is the real prevalence in the population. So there are a lot of patients have symptoms, but they don't recognize them and don't present them. There are patients have symptoms, recognize them, but they don't present it to the physician. And there's also a significant number of patients that have symptoms, present to the physician, but it's not diagnosed. So we just see the tip of the iceberg. Those who have symptoms present to the physician and actually has the diagnosis. So there is a wide discrepancy between the number of patients we see with obstruction and probably the real number of patients in the real population. So if you look at the EPIC study, the number of women that had reported voiding symptoms, it's around 20%, so it's a huge number. And prevalence of voiding dysfunction that you see in referred centers for aerodynamics is really a little short number. So I think this is also a typical case of an urologic iceberg. Well, when you look at the EPIC study, you can see that there is in this Venn diagram a huge difference between men and women. Regarding voiding symptoms, it's clear that women have few voiding symptoms than men, but what is more striking is that most of women with voiding symptoms have also storage symptoms. Very few women has only voiding symptoms. This is a very important fact. This is not only true in the general population, but also true in patients with bladder outlet obstruction. Female patients with outlet obstruction, only 10% of them has only voiding symptoms, and as you can see, the majority of them have both voiding and storage symptoms, and a significant number of them have only storage symptoms. So this makes us think we're talking about a voiding problem, but we see it's storage symptoms. Of course, we know, mainly from men, that there is a clear association between obstruction and bladder overactivity. This may just in part explain this observation. There are reports that women that have been submitted to incontinence surgery that have de novo urgency, they have a mid-rectal kinking in proximal rectal dilatation that is not observed in women with not de novo urgency. Also, if compared women with bladder outlet obstruction to controls, the incidence of the Truser overactivity is higher. We also compared the prevalence of the Truser overactivity in neurodynamics with the Schaeffer grade, and you can see the higher the obstruction, the higher probability of finding the Truser overactivity on neurodynamics. There are a lot of other indirect evidences. There is this study that showed that women with idiopathic the Truser overactivity had lower Qmax and higher p-depth than controls. And also we have evidence from the surgical outcomes of patients that have been operated to prolapse and ureterolysis for previous incontinence surgeries, that they have become better of the storage symptoms by these surgeries. So there is clearly a link between obstruction and the Truser overactivity that may explain some of these facts. Well, but when we talk about voiding dysfunction, it's very important to look, of course, in voiding symptoms. Voiding symptoms are generally more specific of obstruction than the storage symptoms. Mainly the straining, poor stream, and hesitancy are more specific than the incomplete emptying sensation and also double voiding that have not proved to be so specific of voiding dysfunction. So, although voiding symptoms are more specific, its specificity is still very low because a lot of women, most of the women who have voiding symptoms are not obstructed. So this is it's a clinical problem. Luis have also showed that he tried to relate each symptom or symptoms complexes with the Schaeffer grade, and he couldn't find any relation between any symptom alone with Schaeffer grade or any complex other association of symptoms with the Schaeffer grade of obstruction. So it's very difficult to relate the individual symptoms and even symptom complexes to voiding dysfunction. So that's what Luis already said, and most of our urodynamics mentors usually say that the bladder is an unreliable witness, and in the case in a female bladder with voiding dysfunction, this is even less reliable. So how can we diagnose voiding dysfunction in women? Well, first of all, we have to have a high index of suspicion, and we have to take always have on our mind that this is a real possibility, and this is a urological iceberg. So, and besides the normal storage and voiding symptoms that you can see in questionnaires, you have to look for other symptoms, like the feeling of bulge in the vagina, the pelvic pressure, spraying in the stream, needed to immediate revoid, that is very common symptoms, a post-micturition leakage, a position-dependent micturition, and dysuria. These symptoms are usually not on questionnaires, but may have extra information on the possibility of voiding dysfunction. Also, it's very common that women come to us with urinary tract infections, and they have voiding dysfunction. So the infection, this history of infection is very important. Also, of course, it's neurologic history of comorbidities. Of course, we have to record information related to probable causes of voiding dysfunction. Luis already told about that. About them, we have to think that most of them there is just not one cause. We may have more than one causes, and we have to look to think in all of them when we talk to women. Well, the physical examination, of course, the abdominal examination, you can see the big bladder, but the pelvic examination is usually very obvious when there is a prolapse, or even when there is an over fixation of TVT or TOT. And also, of course, the neurologic examination is very important, mainly when we think of underactive or acontractile bladder. Looking at what else can we have to help us in diagnosing, one of the most important tests is the evaluation of postvoid residual. The postvoid residual has an issue that is the variability, because mainly if women are stressed during the residual, or if they are over distended bladder during the ultrasound, they can have higher postvoid residuals with no significance at all. You can see if you retest the residual, a significant number of women have diminished his postvoid residual. Anyway, there is a significant number of women with LUTs that have high significant postvoidal residual. This is usually associated with age, previous incontinence surgery, the symptom score, the parity, and prolapse. So there's a high probability of these women have some kind of voiding dysfunction. Also, even women who have incontinence, urge incontinence, a significant number of them have high postvoid residual. Most of these women have prolapse, voiding symptoms, and they don't have stress urinary incontinence. So in this case, it's very important to evaluate the residual because this high probability of avoiding dysfunction. Also, the International Consultation on Incontinence and the EAU guidelines recommended the post-void residual when evaluating women who have voiding dysfunction. And also women who have complicated urinary incontinence, the evaluation of post-void residual with ultrasound is important. Of course, flowmetry is also very important. It's very in screening patients for avoiding dysfunction. There are usually two ways or two cutoffs to when evaluating low flows in women. One is the 10th centile in the Liverpool nomogram. Other is when there is a lower than 50 mils per second Qmax and a post-void residual over 50. This has been compared, the two cutoffs, and you can see there is a very good agreement in both. And however, there's still a significant, number of, there are some women that are obstructed but have a higher Qmax on flowmetry. Ultrasound is also helpful. Of course, it's mandatory if you suspect a chronic retention, and it's very important to see the upper urinary tract. Of course, you can see bladder stones and diverticular, and to see the urethral kinking, it's more difficult, but in expert hands it can be done. And the detrusor wall thickness has been, there are several reports, but it's most of these reports you can relate it with the detrusor overactivity, but there is no clear relation, unlike men, between the detrusor wall thickness and voiding dysfunction and obstruction. So the detrusor wall thickness has not so much importance in women that it has in men. Cystoscopy can also help in determining the site of obstruction. It's very important, of course, when there are LUTs with pain, and of course after incontinence or PUPS procedures, and where you can suspect of erosion of a prosthesis or something else. There are also some ideas that trabeculations could predict the existence of an obstruction. Actually, trabeculations are associated mostly with age, and there are some associations with detrusor of activity and stage cystocell that must be also can be related with age. So there is no clear relation between trabeculations and obstruction in women. Another recent report has shown that that there is now a trend to use biomarkers. NGF has been shown to be a good biomarker in overactive syndrome, and there is this report has shown that in women that were obstructed due to incontinence surgery or prolapse, and that they had a significant higher NGF in the urine. And after treatment, this NGF would normalize and would be very similar to controls. So this is maybe also could help in diagnosing in the future. However, this is not very specific, as I told you. A nerve growth factor. Nerve growth factor, it's in the urine. You can use it, and also correcting the creatinine has been associated with overactive bladder. So here, as I have previously said, there's an association between overactive bladder and obstruction, and so here there's very few cases. We can really say that NGF is elevated by obstruction or by overactive bladder, but studies has to be done on this matter. So, in conclusion, women with impaired emptying present with high array of LUTs, and mostly are on the storage range, not on voiding range as we would suppose. It's very important to investigate symptoms of voiding difficulty in women that seeking care for overactive bladder. A significant number of them have voiding symptoms, and the voiding dysfunction may be the cause of the overactive bladder. uroflowmetry and postvoid residual measurement are the mainstay of the initial evaluation, very important in screening patients for voiding dysfunction. And when these lead squeezes with high postvoid and residual pressure flow studies are needed. And I think that Professor Paulo and Luis will talk about in the next few presentations. Thank you.